Hi, I'm Joya Jefferson Nuri, and thank you for joining us for Profound Conversations. This is a series of talks with professionals in the medical community about a lot of different topics. Our topic today is the opioid epidemic and what everyone needs to know. For years now, headlines on television, radio, and newspaper have talked about the opioid epidemic. We're hearing stories of people dying, people becoming addicted, people going to jail for stealing it, people switching from the opioids to heroin. But what actually is it? If it doesn't affect your life, you may be a little bit in the dark to talk about it with your family. I think we all should. Let me tell you who's joining us today. Dr. William Lawson. He is emeritus at Howard University College of Medicine, and we thank you for joining us. And for all of our guests, if you want more information, visit our website about their backgrounds. Also joining us today is Dennis Antoine. He is a board-certified psychiatrist and addiction medicine specialist. He lives in Baltimore also. Thank you so much. Not also, you live in Baltimore. Thank you so much for being here with me today. Dr. Antoine, I first want you to define what an opioid is.
Oh, Joya, first, thank you for having me today. I'm really excited to be part of this conversation. And it's a good question. There are a lot of ways of looking at it, and sometimes we parse words to describe it. There's what we call an opiate, and then there's what we call an opioid. An opiate, just to start out there, is what would be naturally occurring. And we think back to probably the history in the United States, thinking of the poppy flower that was brought in during some of the wars. And the extract from that poppy flower is the naturally occurring substance, which is an opiate. And it hits one of the receptors in the brain, in particular, that leads to a pleasurable response. And the more of it that you get, the more pleasurable response that you will be able to receive. And there are naturally occurring opiates in our body as well. Things like endorphins and things like that. We get a high from different activities, but it doesn't rival the high that you would get from that naturally occurring extract from the flower. Then you take a different step towards what we call an opioid, which is sometimes encompassing the natural part, but also is the synthetically or almost factory made drug that also hits those receptors, but is much more potent at times. That's when you get into things like the fentanyls and the things that are more prevalent nowadays that are synthetically made, sometimes for medical purposes, and then they've been diverted into what we now see as use that can be very harmful. So all of those, the opiates and the opioids, are intended to hit that receptor.
Opiates, are they as addictive as the opioids?
Well, it depends. There's a large range there. And some of those opiates, for instance, diacetylmorphine, if you were to say it that way, you would think, oh, that's just a regular old medication that's prescribed. That is the name for heroin. And that is also a cousin, if you will, of morphine itself, which we all know is prescribed by doctors. Mm-hmm. So they can be just as addictive, but it's also how they're prescribed, how they're monitored, and ultimately how that person uses them and the consequences that might come across because of the use and interaction with other people in the sphere. So it all depends on how the rest of the context is in that picture.
Okay, Dr. Lawson, would you like to add something to that definition?
Yeah, I wanted to add that actually these drugs have been around a long time. They, of course, occurred in nature, but also during World War II, the Nazis needed something for pain, so they synthesized several agents, including ones such as methadone. And recently, the technology has advanced to the point that one of the agents, fentanyl, became extremely popular because it's 100 times more potent than morphine. And as a result, individuals who divert these drugs illegally can get a lot more bang for the buck for these agents. I might add the endogenous opioids are not as potent because they're released in terms of neurotransmitter endings. But if you look at some of them, like dynorphine and some of the others, they're far more potent than morphine itself. It's simply that it's not cost effective for many folks to go synthesize those endogenous opioids. But they play a very important part in terms of functioning, in terms of providing release from painful situations, in terms of bringing some euphoria to some individuals. It's only that we're not using these agents as nature intended to when we made them available for health professionals and for everyone else. So the opiates, the concept of opiates is not something unnatural or came out of, but it's part of a natural response that's we've evolved in terms of being able to deal with pain and pleasure.
The first time I ever heard the term fentanyl was at the death of Michael Jackson. Was that a new drug in 2008, 2007, whenever Michael Jackson died?
It wasn't brand new at that point, and I think there were other medications in the mix there, which is another thing that's coming up more recently, that people aren't often just using one thing. I believe there are other medications like propofol and that were in the anesthesia realm. I think what we're finding is that the medical utilization of those things and where people are using them in the surgery procedures or after they get discharged, eventually, as Dr. Lawson was saying, they might end up in ways that we didn't intend. And that's where you get towards using them, as Michael Jackson was using them a little bit more. So it wasn't brand new in 2008, but certainly got more spotlight at that time.
Right. Dr. Lawson, you mentioned that this goes back to World War II when the Nazis figured out how to use it. You said it was a natural poppy that I first heard of during the Vietnam War, as something that brought euphoria to soldiers. They got back to this country with it. But over the last 5 or 6 years, there was a period there where every evening the nightly news would open with a story about opioids. And there were Washington Post front page stories about opioids. There's lawsuits, billions of dollars being flown around here. HHS, CDC are involved. What happened over the last 5 to 7 years, Dr. Antoine, to make this headline news?
I think there's been a few things at play, and it's a storm, if you will, that's come together. Part of it before that time period was that there was more prescribing in the medical setting of opioids for pain, and there are different factors that went into that. Partly that certain providers were told this is what we should make sure is treated properly, and some of those advice that was given back then may not have been the right thing, but it was given. So you saw prescribing of opioids going up. At the same time, as we got closer to this 5-year period you talked about, there wasn't necessarily the best teaching of how to manage people once that opioid course was done. So an antibiotic, when you take it, it's 7 to 10 days, you're done and you're good. But for opioids, that advice wasn't always given, and it wasn't always trained properly for providers. So sometimes there was a tough landing after the end of that course, and people had to find different ways to cope with the withdrawal from those opioids. And that would lead to misuse with other things. So that storm coming together and increasing of opioid use led to it really going very wide across the country. And in about 5 or so years ago, there were a series of strategies put in place by HHS, the Health and Human Services, to look at different ways of treating opioid use disorder. And that started with making sure there was more funding, making sure there was a better look at the data, making sure that there was increased access to treatment to ensure that people could have some type of relief from opioid use disorder, since it was spreading for the multiple factors and probably more that I didn't mention there. So I think that's why the focus became that much brighter, at least from the provider standpoint and in the research standpoint, in the past 5 years or so.
Yeah.
Yeah.
This,
Part of it also is, and there's racial politics involved as well. There was actually a major problem in terms of the 60s and 70s in terms of the opioid epidemic among African Americans, particularly in terms of New York and Harlem and others. The idea was that opiates were widely used by jazz musicians and others. And as long as it was in those limited populations, there wasn't a national outcry about this. It was enough of a problem that some people like Bennett Prim, who created the first Office of Drug Abuse, went out to try to develop some effective treatments, but it still was not recognized as a national problem.
mm-hmm.
Then recently, when these agents became more available and used not just in the African American community, but among the white community, the data came out showing that the overdose rate was actually contributed to a lowered life expectancy for white males, that it then became recognized as a major health issue. And it was a contribution of two factors coming together. One was that, at least in my training and Dr. Antoine's training, we were told to do what we could to make sure that patients weren't exposed to too much pain. That pain became the fifth vital sign. If patients had pain problems, we should try to reduce the pain as best we could. But in fact, the trade-off was that many people began to use opiates to deal with this. Much of the public began to recognize that we don't have to have experienced chronic pain. We have these drugs that are relatively safe, who we use to deal with pain, and also gave a little buzz afterwards. And what we have is a situation now in which many people are using it. We're in an older population now. People are having aches and pains, but we're dealing with them by having what was thought at the time to be a relatively safe remedy to reduce pain with minimal side effects.
Yeah, I previous profound conversation episodes, we have discussed at length the trust factor between the medical community and the population, especially among the African American population. And this is a situation where, in our previous shows, we were talking about trust around the transplant process. Do you trust the doctors? Do African Americans fear that they'll be let to die so that somebody else could get their organs? And the doctors we interview recognize that that's a real problem, that trust factor. And history has proven, not just for African Americans, but in particular African Americans, where there's no trust or very little trust to our doctors. From everything I know about this opioid epidemic and everything you're saying here, this is a problem brought onto the community by their doctors. And everyone trusted, when they got this prescription, that this was going to be okay. How do you address that? Either one of you.
I think first you have to acknowledge the history that is there. You can't just say it wasn't anyone's fault and now let's just move on. I think you have to recognize that past and recognize that there is probably intergenerational trauma, not just trauma within one individual, but intergenerational trauma, as Dr. Larson said, starting from the 60s and the 70s up until now, that we have to recognize. And as two Black psychiatrists, we know that the psychiatry field has an added layer of a lack of trust due to different types of diagnoses before the 60s and 70s that I think have earned some distrust on the part of the African-American community and persons of color. So first starting there and recognizing we understand why there can be distrust. But then starting with reliable persons, people who have an intimate knowledge and background and connection with these communities to establish a safe trajectory forward on how we can relieve this pain from the community as well. Because I don't think the community wants to have this pain, but it has to start with people that are trusted and are willing to stay around for a long period of time, not just for a couple of years for a grant, but sticking it out for something that's going to be sustainable and helping the community long term. So those would be my initial thoughts.
Okay. Dr. Lawson, I have a follow-up question, but Dr. Lawson, I would like you to respond to that.
Yeah, I think that just bringing another point, and that is that there was a study showing that many white physicians simply didn't trust African Americans with pain medication. And in fact, it showed that African Americans are much less likely to get pain medications than other groups. This sort of added to whether or not the physician is looking out for the best interests of African Americans. So it became an issue of how to address this point. And it's an important point of recognizing that sometimes to address problems, you have to pay a price in terms of looking at the benefit risk ratio. Mm-hmm. The other point that's extremely important is that many African American physicians, all physicians, were given misinformation about the relative safety of these agents. And the marketing, and physicians are no different than anyone else. The information they got wasn't something you got from medical school, especially when you got a new product on the market. You get it from the companies that are selling the products. Mm-hmm. And they're correct in one sense. If you take the drugs as prescribed and don't go beyond those, many of these agents are relatively safe. But and many folks in the community recognize that there are drugs in the community that were off-label, that were out in the streets, that were unsafe. But they thought that when they were prescribed by the physician, that there was supposed to be another layer of safety, and that these are supposed to be drugs that have been approved by the FDA to be safe and effective. And what they found was otherwise, that people were dying. Mm-hmm. And this, along with the information about such programs, the Tuskegee incident, in which African Americans were untreated when they had syphilis and so forth, added to a narrative in the community that the medical provider may not have your best interests in heart. Mm-hmm. So clearly there's a need to make sure that our providers, even if they are working not in an academic setting, but in the community setting, get the latest updated information, and that information has been appropriately addressed in terms of the usual regulatory organizations.
Yeah. Dr. Antoine, you said earlier about this 5-year HHS program that was going out into the community and treating the addiction. What is going on to treat the doctors who either got misinformation from the pharmaceutical companies, as Dr. Lawson has said, or are withholding from a community because there's some racial bias there about how Black people handle pain medications, and like we're naturally addictive people. I don't know if that's true, but what is happening? What training are you getting from this money, from this? What are doctors being told? Now, I have a friend who had hip surgery and got no opiates. Opioids. She was sent home with Tylenol so it sounds like the medical profession is going the opposite direction when she had pain greater than a Tylenol can manage. Right. What are doctors? What training are doctors getting?
So, and I think there's a system in place that not only are doctors getting training for certain things that we call risk evaluation and mitigation strategies, which is a real big way of saying we want to make sure you're giving it, but giving it the right way and not giving it in a harmful way. So that's part of that strategy that's been put out there. We're also seeing that more people are getting access. So for instance, over the past 5 years, there have been acts that have expanded how many folks I can treat at the same time with medications like buprenorphine, things that require special licensing. So before it was I could only hold on to maybe 30 to 50 folks, and they raise that level so that people that are willing to give that good care, they would have access to do more. I think beyond that, there's a focus within that 5-point plan on looking at data. So certain elements are coming out to point out what Dr. Lawson said, that we just need to know that Black people aren't getting the medication. And then part of the data that's also coming out that's getting hopefully more publicizing is that even though there's been a steady rate of opioid overdoses overall, and in some places declining, for Black men, it's actually gone up 38% over a period of time in the past 5 years. So part of it is the data, and then other parts of it is making sure they're monitoring of the system to ensure that doctors have to check certain things. And making sure that it's done properly. So it's a multi-pronged approach, but I think all to make sure people are doing it and not just being trained, because teaching isn't always learning. You have to make sure folks are shown the right way and are doing it the right way.
Were doctors ever held responsible legally?
Absolutely. When doctors have different programs such as opioid treatment programs, which I'm director of one, or have different facilities such as buprenorphine programs, the DEA still does checks. And they definitely ask at these visits, are there any people you're concerned about with their prescribing practices? And you've seen places like pill mills that have been closed down in multiple states where there are financial and incarceration consequences with that. So there is responsibility there. Are we exactly where we need to be? No. As Dr. Lawson, though, said as well, this system needs to be looked at to make sure that companies aren't putting out misinformation, and also for certain things such as insurance companies, making sure that there aren't barriers put in the way of people getting the right treatment. Just because a doctor prescribes the right thing doesn't mean an insurance company is going to fill it.
Right. Dr. Lawson.
Yeah, and also there's extensive programs that's been promoted in terms of education for organizations that support physicians, such as American Association for Academy for Addiction Psychiatry, as well as the equivalent organization for primary care, surgery, and others. And these have been given large sums of money to go into the communities to educate folks. Moreover, it's also, as I'm an assistant to the dean for one medical school that's incorporated this in terms of their training programs as well. But again, part of the problem is that many, especially African-American, Latino, physicians, much more likely to work in communities in which there are limited resources and high volume. And so they may not often have the opportunity to get the kind of educational knowledge, the degree to which it can be practically useful. We have requirements in terms of continuing education, but it assumes that the person will have the time and the effort to be able to devote education time, as well as the very real patient needs that they have to deal with as well. And one of the ongoing patient needs has been folks seeking relief from pain. And we had some newer technologies that can help deal with addictions, such as drugs, such as buprenorphine and others. But what we find again, and my own efforts have been looking at getting new technology into the African-American community and Latino community and the physicians. And we found that drugs such as buprenorphine are less likely to be used by African-American and Latino physicians. They simply aren't made as aware of it. And also there are regulations in terms of whether or not insurers will pay for the use. And so as a result, folks can get addicted, but the usual way of dealing with it is either by the correctional system or by some sort of therapeutic recovery method. And unfortunately, the correctional system approach has been the one that's been emphasized in this country. Are doctors being prosecuted prosecuted for use of these agents inappropriately? Absolutely. But it's also, we've seen the case in which physicians who have used appropriate treatments to try to reduce addictions are themselves being prosecuted as well. So
and why is that? Why is that? Why would a doctor who's doing it appropriately be prosecuted?
Because of lack of knowledge by legal providers or by the criminal justice system. For instance, we've had great difficulty in changing the dosage requirements, which are set by law in some places, for getting buprenorphine. And so what we find is that people get inadequate buprenorphine, and as a result, they end up using drugs again. The physician who provides the larger dose of buprenorphine could be, and in fact have been, prosecuted. Mm-hmm. So unfortunately, there's a lag between technology knowledge and the criminal justice system.
Okay. But in doing the reading to get ready for this show, I realized, and I guess this is a twofold question about the function of the brain and addiction and the medical profession and the advice people are getting. From some of the articles I read, doctors who prescribe opioids tell their patients stay ahead of the pain. So you're going to take the opioid on a schedule long before you are in crippling pain, because the body doesn't heal. From this article, the body doesn't heal when it's in pain. So you're telling people to stay ahead of the pain. So you're going to take this opiate 3-4 times a day, ahead of on a schedule, 8, noon, whatever the schedule is. And then you give people a prescription, or doctors do give a prescription that might have 90 pills in this bottle. So you're telling them to take it 4 times a day. You're going to give them 90 pills. Now, can the brain withstand having that much opioids come into their body for maybe a month? What are we setting it up for addiction, Dr. Antoine?
Well, I think what the field has really shifting towards in terms of the training that we've had, at least for the past 5 years, is to more of a symptom triggered approach. Because if we were taking the approach that you said, where it's just a steady dose all the time, it's very similar to eating a salty food every day. You're just going to get used to it. Mm-hmm. And after a while, you're going to need a little bit more salt because you stopped tasting the salt that you were tasting before. But that's not how the field is going about pain treatment at this time, or even withdrawal treatment. We're shifting more towards having a baseline, if you will, just so we get most of it. But as the pain spikes up above a certain level, then you add a little bit of salt. And then as the pain gets down, you'll need less and less of it, or eventually you'll get down to that baseline, and then you can taper off very gradually to get to nothing. But you're right, if 90 days of a steady dose, man, the brain would be like, all right, I need to shift now. And your receptors would change. Do we know the exact time point? That varies from person to person. But that would be a tough approach if it came that way.
Yeah.
And another point that I want to emphasize is that a lot of our prescriptive practices involve the patient having responsibility for taking the medication. And so we assume that we have a responsible, well-informed patient. Unfortunately, many of us have found is that patients only hear about 30 to 50% of the information that's provided, almost never read the package inserts, and essentially try to take the medication as they feel they need it for their own personal needs. Mm-hmm. And that's going to be an ongoing issue if you're in a country where it's a free country, and which you don't try to micromanage it and end up doing the opposite.
Yeah, I'm wondering, going back to Dr. Antoine's answer about, you hit that pain threshold and then you take it. But everybody has a different pain threshold. I mean, stubbing my toe might be crippling for me, or stubbing my toe, I may not notice. So how are doctors educated to educate their patient about what that threshold really ought to be to help avoid these addictions?
I think some of that starts with the conversation to really paint a good picture, because just walking in the door, you won't know the answer of, all right, 5 milligrams of oxycodone is going to cut your pain down to this. I wish we had that test. I wish we had that imaging or however we do, but we don't. So the other part of that is everyone has a genetic part of them that dictates the response to those medications. And we don't know that coming in the door as well. So it needs to be a close communication up front, usually with types of events that would lead to needing those medications. You should be in a hospital for a few days or a couple of days to start that conversation, and then have case management or a way of checking in to adjust pretty closely, probably from week to week, in case someone overshoots or undershoots. I would say coming in the door, there isn't a set way of doing it that we're trained. It should be that conversation. 85% of the diagnosis is the story.
Yeah, I want to just add to that also, and I just want to emphasize, because I do research in pharmacogenetics, and what we found is that there are real ethnic differences in terms of how rapidly medications are metabolized. African Americans and Latinos, for many drugs, what we call slow metabolizers, that is that the drugs themselves or stay in the body longer and may have other effects. Unfortunately,
and Doctor, why is that? Why would an African American genetic, Latino genetic be different than a white person's genetic as far as how long the drug takes to metabolize?
Yeah, I want to emphasize that this is not individual. These are what we find in terms of looking at population studies. So not all African Americans slow or fast metabolize, but there's a disproportionately more. And it's part of it has to do with differences in one theory is that in terms of the going across the middle passage, that different people survived because they had different ways of metabolizing certain substances in order to survive. Survival rate in the middle passage was around 50% for many folks. Also exposed to certain kinds of foodstuffs early in life. So there's a variety of factors that come in, both at the receptor level as well as at the level of how these agents are broken down, that can result in differences in terms of handling of these agents. And again, I want to emphasize that Sherwin said that that there's some natural ways in which our bodies, in which we've evolved to deal with different substances, but opiates coming in as medications isn't part of natural development, of the evolvement of the human race. This is all a recent development, and our bodies have simply not evolved to the point that we can determine easily what is the best one for dealing with pain and which isn't.
Yeah. Dr. Antoine, do you have a response to that or add to that?
No, I think the body has different ways of adapting, and I think the middle passage piece just paints how genetics are part of it, but it's also what happens around us. And that's something that there's a lot more research to be done to figure out, how we can make sure that we pay attention to, how substances affect us, so that when we're walking into the door with the doctor, we can say, well, this is what normally happens with me. Do you think I should adjust one way or another? All that knowledge is helpful to shape the conversations that you have with the doctor. And so that it truly is a bi-directional, two-way conversation, not just a doctor telling you how to do something.
Right. I'm wondering based on something that Dr. Lawson said about there are studies that look at the difference in how our body metabolizes drugs based on our genetics. I'm wondering, has those studies infiltrated into the medical profession as normal history? But my suspicion is, at first it was race-based and nobody cared. They just treated you, make a decision about you based on their own prejudice, and their own arrogance. And maybe once the world started to get a little bit more sensitive, they felt that they were racist if they started telling somebody, well, I can't give you the same thing I give Johnny Pookie because you do it differently, even though that might be the truth. We don't do it because we're oversensitive, or we don't do that sort of analysis because the vast majority of the medical profession doesn't care about the race differences?
Well, I would go to the insurance companies for a second, because the question in that genetic analysis is who pays for it and who authorized the payment for it. I think more recently there's been the ability to perform those analyses, but I would say it's not widely publicized how to get them for patients. And I would also say that oftentimes it would not be approved right away. There would be a lot of out-of-pocket costs for that. So there is a barrier there that doesn't fall within the doctor's hands. We know it can be done, but we also know that the hundreds or even thousands of dollars that go along with that, for my patients, 95% of my patients on Medicaid, it might not be doable.
It's not doable.
So that's the other piece of it, that the medical profession knows it exists. I'm actually a co-investigator on a couple of studies right now doing those studies. But how to get it paid on a day-to-day, that's that next step, almost that stage 5 implementation that we say, how do we make it available to everyone? And insurance companies can play a role with that.
Okay. Dr. Lawson?
Yeah, there's several pharmacogenetic companies that's going on offering tests. But for the average practitioner, it's just not cost effective. And so in terms of everyday decision making. And also, a lot of what we're talking about, again, is we talk about the genetics, but also, as Antoine noted, is belief systems. And the fact was that many Caucasians who treated African-American patients simply believed that African-Americans were impermeable to pain and simply did not offer the kind of support that they needed. And also working on the idea that even find some of the textbooks I looked at in medical school saying that African-Americans were more likely to be substance abusers, when in fact that is not true. So these kinds of belief systems still permeate our culture above and beyond on the extent to which the physician may care. There's a background belief that may influence decision-making. And one point that Dr. Antoine noted is the importance of getting an appropriate support system. It's just the patient and the provider, but good programs make sure that we have patient advocates, that we have nursing support, that we have recovery support, so that if folks do get into problems or have questions, they can have it addressed. Unfortunately, this kind of integrated care simply is not available throughout much of the country.
This brings me to the $5 billion settlement from Johnson & Johnson. And as I read where that money goes, it seems to me it's just cycling back around the same players. Who's doing the drug rehabilitation centers? Who's doing whatever? It didn't seem to me like a lot of that money is going to reach the hands of practitioners that deal directly with the African-American community. It was pretty generic. And then I want to add to that, back to what you were saying, Dr. Antoine, about bringing in the insurance companies. Should it not be the pharmaceuticals company responsibility to do this level of research, to make sure that their medications are doing the right thing? Of course, the insurance companies are going to try to save money. That's their mode of operation. And are they particularly responsible for what a pharmaceutical company is selling to a doctor and what research a pharmaceutical company does? So in that $5 billion, I didn't see, now granted, I don't see the entire lawsuit, but from what I read in the media, none of that is going to doctor education or to any of the studies that would specialize the psychiatry that would be needed for this. So I'd like to get your response to my statement and in general to the $5 billion that Johnson & Johnson allegedly is going to put into the pool.
It's a great question. Great couple of questions there. I think we have a deeper discussion on our hands at the state levels. And I was recently part of that discussion for folks within the Maryland pool who are thinking about what's going to happen with this money. And there are bills and policies that are being introduced at the state level to decide how some of this is going to be divided up.
Okay.
And it's going to be interesting. We said some of the same things, like we don't see how the money's going to get to this research or how to do that. And I think it's on the states to do things like what Maryland is doing, which is building a racial disparities opioid task force to make sure that there are policies in place to add the ethical principles that you're talking about for this $5 billion, because people have their professional responsibilities and the individual morals, but ethically, there needs to be an equal distribution of this to make sure that we're looking at these health equity issues. And there's going to be more of a debate for that. And I do hope those funds get there. It's just not quite clear in my mind that, as you said, that it's mapped out that way.
Yeah. Dr. Lawson, a response to my statement and the $5 billion?
Yeah, I think the good news is that we went through this before in terms of the tobacco settlement. And many of us learned, I was in Arkansas at that time, and almost all the money went to reduce the state budget. So there's an awareness that the money is going to be diverted for non-specific uses, much more so than it was before the tobacco settlement.
Okay.
Unfortunately, Dr. Ankron noted, the devil is in the details.
Yeah.
And whether or not there's going to be any kind of systematic way to, because you got the fox monitoring the chicken coop now, a systematic way of making sure that that money is going to go to the purposes this is intended. On one hand, we say, well, the good news, we're not giving it to the federal government because they're going to waste it and so forth. But the bad news when you give it to local entities is you have local interests becoming involved.
Right.
And you also must look at a way of seeing how can it get out to community-related groups who often do not have the infrastructure to be able to even apply for these grants.
Right.
And many community groups simply don't. Just being, many of them are folks trying to do good, but now you're talking about setting up both at distribution centers, setting up ways of writing, monitoring data, setting up outcome measures, which many community organizations simply do not have the know-how or the expertise or the resources to do it. So it's a tremendous opportunity, but it is the devil in the details, and the extent to which community groups will have the political clout to be able to keep the money from being diverted for uses that weren't originally intended.
Well, Dr. Lawson, you just confirmed all my fears. Thank you. Thank you for that. You just confirmed all my fears about $5 billion. I wanted something that Dr. Antoine said. He said something about ethical practices. And I talked earlier about building trust. In our earlier programs, we talked about co-work. And that would be a relationship between the doctor, the medical doctor, the psychiatrist, the caregiver, whether that's a spouse or anyone else, and the patient. And is there room in this that we can now have a conversation? You said that all the learning that will happen, you're in the hospital for a few days if you're ever given this, if a doctor gave you this prescription, you're in a hospital for a few days and there's a conversation. But is it a dialogue or is a finger point? This is what you must do. Is there an engagement? Is there a co-working between the patient and the doctor or the nurse who's giving this education?
Should there be, or is there? I think is the question there.
Is there? First,
right.
Is there?
I think as there's more training and information on the best ways to work with people, principles and ethical principles that will come out will be autonomy, and also things about beneficence, making sure you're doing right for that person, and thinking about doing it in a way where there's informed consent. And part of that means that you tell the person what's going on, make sure they understand, and work with them to do something that's feasible. Don't just say, "All right, here's what you're going to do, no matter what you think," and argue with them about it. You got to think of different strategies depending on where they are. And that's where training about things like motivational enhancement, if there is some ambivalence about which way to go, or having a good understanding about a person's social context and their ability to take these medications regularly before you just give a prescription. That's very important. As psychiatrists, we take that context in more naturally, and we probably have a little bit more time than other specialties. But as we get more training and information and practices, and hopefully in policy to make sure people are doing these things, I think we'll make the shift to what should be to what is. I can't with certainty say, especially with the data that Dr. Lawson talked about, where African Americans aren't getting these medications. I can't say that we're fully there right now.
Okay, Dr. Lawson?
Yeah, I want to note the work that a colleague of mine, Lisa Cooper, has done, in which she went out and basically looked at the relationship between patients and their physicians, particularly African American patients, and basically found that in many instances, they didn't communicate with patients, or when they did communicate with patients, did it in a dictatorial stance. She's promoted programs in primary care to promote more interrelationship dialogue type of method, and found it's been very effective in terms of improving patients' adherence and also outcomes. And psychiatry has begun to do that, but much of the field still is not there yet. A lot of us give lip service to it, but it simply doesn't happen, and it gets overwhelmed by the other needs that exist in terms of the medical community. So that would be ideal to ensure that we monitor, keep track of, and make sure that we have a relationship between the provider and the patient in which they're much more of an even setting, and also in which the expectation is that providers successfully educate the patient, and that the patient feel that they can get the information they need to address their needs. Again, that's the unfortunate, still the exception. It's an ideal that we're working towards, but practically, and also unfortunately, there's not many incentives to do this.
I'm wondering if, even though it's my question and it's my hope that there'll be a co-work, and like you all saying it's out of the norm, I'm wondering as you were answering Dr. Lawson, I'm picturing the Medicaid. I used to be a reporter, and I would do a lot of city news here in DC, a reporter and a producer, and you would go into the offices of the Medicaid doctors, the doctors who took it, and you'd walk there and you'd go through the lobby, and you would see that the people there were old, very sick, or very young, with very young children. And there'd be 20 people waiting in the waiting room. Maybe that's an exaggeration. There'd be 15 people waiting in the waiting room. There'd be one doctor in this practice and maybe 2 nurses. So how is that possible for that one doctor to take on 15 people and 15 individuals in the way that we're talking about now? And what help does that doctor need?
I would say, this is where health equity comes into play, because it's not just about making things equitable. It's about what investments would have to go into that to raise the value of that care. Part of it's going to be finding a way to help that doctor paint things more efficiently. Meaning, how can you get that information before the patient gets into the room? We've been doing something now at Helping Our Mission. This is a homeless therapeutic community in Baltimore, where we actually have, myself as one of the main doctors, but we have about 200 men there in the building, and they have to come for treatment. But we try to get a snapshot of who they are with standardized outcome measures. before they step in the door.
Okay.
And we make it easy for them to access that. I think in other ways, as cell phones become more accessible, it's not quite there yet, but there could be ways to send people, a questionnaire beforehand just to say, hey, take a couple of minutes, let me know your pain, let me know how depressed you might be feeling right now, so you can have a running start.
Right. Right.
And that is part of what this $5 billion, not the opioid restitution fund, but HHS is thinking about to make things more precise. That can give that doctor a running start, and also making sure the work that they do gets better reimbursed, because every state thinks about the Medicaid reimbursement. And if there's a push on that policy side to increase the reimbursement, that doctor could have a more cost-effective way of doing things. As Dr. Lawson pointed out, that cost-effectiveness matters that much more for that doctor.
Mm-hmm. Okay. Dr. Lawson, how do we help that doctor?
Yeah, and the part that I would probably didn't mention, but it was the manpower problem, woman power problem.
Mm-hmm.
That is that the number of African American physicians is actually about the same number as it was in the 1960s.
Wow.
Similar problems just with the Latino community.
And Dr. Lawson, why is that? I mean, we're talking 40, 50 years. Why is it that we don't have more Black doctors?
Part of it always goes back to the educational system, in which unfortunately African American males are diverted elsewhere. We find it happens in the 10th grade that African American males are less likely to get the basic science courses that they need to be able to go further. There was other distractions in the community in terms of the teachers themselves, in terms of what kind of careers should folks think about, and also the huge entertainment system. If you want to be successful going Black, go into entertainment. Whereas it's a lot harder to become a Michael Jackson, especially if you're 5'6", than it is to become a physician. And unfortunately, there are efforts in many communities to try to change that narrative, but it's overwhelmed by the huge message that's come from the larger narrative of our society, and that is that the best route for success will be to get involved in terms of these areas that are not related to medical care. And going into a healthcare field and medical field is hard. It is not easy.
Yeah.
And if you're first, second generation in your family, to have any money, to have education, it's very, 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 very difficult.
You don't have the support system.
And the other need that you hinted at is that we have some technology now. Thanks to the internet, there's many more opportunities to be able to spread services with fewer people. I have over 1,000 patients on a system, on an internet network for psychiatric services. But I have it because of the availability of the internet.
Okay.
Many communities, African American communities, rural communities, low income communities, do not have access to the internet. I mean, it's not there. And as a result,
we found that to be true during COVID. That really got emphasized during COVID, when kids couldn't go to school because there was no internet where they were, and schools went virtual. Yeah, we found that. We have 5 minutes left to go in this program. It's been very stimulating. I want to thank you both. I will thank you again. But as far as this opioid epidemic is, just briefly tell us, what would be your dream for moving forward? They gave you $5 billion. Or, I'll take a better question. And on top of poverty and racism and crack addictions and high infant mortality rates, what has opioids done to us as a race of people in this country?
I would say, and I'm going to try to answer both at the same time, the money and the effect on us as a community. I'd say we need to try to re-heal the community, because underneath that, with or alongside that, there have been reminders over these past 2 years of racial disparities in the incarceration system, in terms of the police brutality. There have been reminders that COVID itself has affected Blacks more so than other populations. And there's been another separating of the community because we've been distanced in different ways. And the COVID virus itself has had some disparate effects on our community. So if there is an opportunity here is to put more of these supports in place so we can heal together, more community supports, safe places at night for children to grow up with so they don't get into the cycle in the first place. Support for families so there can be healing for the trauma that probably rose even from the abuse standpoint during this COVID times. And then also treatment for opioid use disorder. So it's a large approach that's needed to heal the community because for several reasons we've been reminded and re-injured over these past couple of years.
Okay. Dr. Lawson, you'll get the final word.
Yeah, I just want to emphasize what Dr. Antoine said. The sad part is that much of what we're seeing now is not new. The good news is that we survived it before by being creative and looking at utilizing the resources within our community to address these concerns. The opioid crisis is tied in with the disparities we're seeing in terms of COVID, with the high homicide rate, the high suicide rate, and the mortality associated with chronic diseases. Addressing this issue in terms of generating those resources to reduce these disparities will, I think, have a benefit across the board in terms of improving the outcomes for African Americans and for other groups as well.
Okay. Dr. Antoine, Dr. Lawson, I thank you so very much for an hour of your time to share your wisdom around this crisis in our community. And I hope when it stops, when the news stops covering it, we don't stop the work toward finding a cure and better treatment maybe than the opioids. And so thank you very much for everybody from on this team for everybody on the team of Profound Conversations. I'm Joya Jefferson Nuri, and we thank you for joining us.